Well, good morning, everyone. Nice to see you all. Thanks for coming to Grand Rounds today. We're excited to have Dr. Fuchs speak to us, and I will turn it over to Dr. Levin to introduce him.
Thank you, Dr. Thomas. Good morning, everyone. Welcome, Dr. Fuchs. Dr. Fuchs is a scientist in the groundbreaking field of computational pathology, focused on the use of artificial intelligence to analyze images of tissue samples to identify disease, recommend treatment, and predict outcomes. In October 2020, he was appointed co-director of the Hasso-Plattner Institute for Digital Health at Mount Sinai, Dean of Artificial Intelligence and Human Health, and Professor of Computational Pathology and Computer Science at the Icahn School of Medicine at Mount Sinai. Dr. Fuchs's work includes developing novel methods for analysis of digital microscopy slides to better understand genetic mutations and their influence on changes in tissues. He has been recognized for developing large-scale systems for mapping the pathology, origins, and progress of cancer. This breakthrough was achieved by building a high-performance compute cluster to train deep neural networks at a petabyte scale. Before joining Mount Sinai, Dr. Fuchs was director of the Warren Alpert Center for Digital Computational Pathology at Memorial Sloan Kettering Cancer Center and associate professor at Weill Cornell Graduate School for Medical Sciences. At MSK, he led a laboratory focused on computational pathology and medical machine learning. He co-founded Page AI in 2017 and led its initial growth to the leading AI company in pathology. He is a former research technologist at NASA's Jet Propulsion Laboratory and visiting scientist at the California Institute of Technology. Dr. Fuchs holds a Doctor of Sciences from ETH Zurich in machine learning and a master's in technical mathematics from Graz Technical University in Austria. Thank you very much for joining us today, Dr. Fuchs.
Thank you very much for the invitation and for the very long and kind introduction. It's great to be here. So I'll try to keep the talk short so that there's enough time for Q&A. But also, if you have questions during the presentation, don't hesitate to interrupt me. It should be interactive, and I hope you're all going to learn something today. Let me share my slides. Here we go. Okay. So today I'm going to talk about AI in general, what we want to build at Mount Sinai, and I'll exemplify that with a project from my lab in computational pathology. Good. So I have one disclosure, and you already mentioned it in the introduction. In 2017, we founded a spin-out of MSK called Page AI. Page stands for Pathology Artificial Intelligence Guidance Engine. I have 5 slides regarding the FDA approval from Page that could be interesting for the larger group, how we can really build clinical decision support tools and then get it through the regulatory process. Otherwise, it's all basic research from my lab. I have the pleasure to be the co-director of the Hasso-Plattner Institute at Mount Sinai. So that's a collaboration between Mount Sinai and the HPI in Potsdam. So the HPI is a technical school like CMU, and the collaboration allows us, for us at Mount Sinai, to tap into the technical pool of experts and knowledge at Potsdam in Berlin, and also allows the students there to work on interesting medical applications. Everything I'm going to talk today is, of course, only possible because of all the fabulous people I have the pleasure to work with here at Mount Sinai, but also before, of course, at Sloan Kettering. Okay, let's start really very high at the top. So if you think about AI today, most people fall into one of these two camps, either in the hype camp or in the cynicism camp. On the hype side, you have quotes like AI is more profound than electricity or fire from the Google CEO, and it will, of course, immediately cure all cancer and replace all work. And on the cynics camp, you, of course, have people saying, oh, it will never work. Machine learning and AI doesn't work like the human mind, so it can't possibly be of any use in clinical practice, and so forth. So what we are trying to do is something very practical. So we in the middle here want to build clinical grade AI. So these are large scale machine learning systems with utility in the clinic and that are also good enough clinical grade for the work in the clinic. We'll touch upon what clinical grade means in practice. The lever we are using to do that is, of course, machine learning. You heard about that, of course, in many, many talks, I'm sure. At Mount Sinai, the vision is really to infuse all the various departments and initiatives with the capability to use these modern technologies that help us to grasp with the data in the various areas. If you think of data in general, healthcare and medical data is the fastest growing source of data. It vastly outpaces, for example, all of media, entertainment, financial data, everything. And to that end, machine learning, of course, is only a function of that data. So it's the only means we have scientifically to deal with these large amounts of data and build meaningful systems out of it. I'll explain how that could be done with one example in pathology. But everything I'm speaking today can, of course, also be replicated in different areas. Think of dermatology, genomics, proteomics, anything really where you have vast amounts of clinical data. And part of my role at Mount Sinai is also to help you and everyone to build these kinds of systems. Okay, I don't have to tell you how pathology works. I can skip that, that's for the computer scientists. Point being, you really end up with a lot of slides. Mount Sinai produces 1.6 million slides every year. What you see here is an example from Slide Catering. That's the stack of GU slides only for one single week in Dr. Reuter's office. And then at most places, so 95% of places in the US, a human still looks through a microscope onto a glass slide. So to that end, pathology has not changed in 150 years. Mount Sinai is very modern here to the end that a large part of clinical sign-out is actually already done digitally, which is very unusual and of course fabulous for our institution. After that, these slides are stored in these vast archives, which are really a pristine example of dark data. So if we could take advantage of these for science, that would be, of course, fabulous. What we see here is a digital slide scanner, and it's only in recent years that these scanners actually got good enough that you can digitize these slides in pathology, and you end up with these very large images. So here's an example in dermatology. It's actually one of my moles. And at the highest resolution, so you have 100,000 pixels times 50,000 pixels, and all your holiday snaps would fit onto one of these slides. If you zoom in, you see, of course, the layers of the skin and a vasculature. And at the highest resolution, you see cells, cell nuclei. And you're interested in building systems that can find the cancer, grade the cancer, classify it, and hopefully even predict response to treatment and outcome. So why is that important, and how does the FDA see pathology here? And that's something that's, I think, interesting also from a medicine point of view. So what you see here on the left, radiology, mostly ultrasound, MRI, but also dermoscopy, CTCs, even liquid biopsies and so forth. To a large degree, these are perceived by the FDA as screening technologies. And to that end, you actually have approved AI in that space. In radiology, there are more than 250 approved AI systems today. Because the view of the FDA is you can always go back and get another CT scan. I don't think that's practically very true, but that's their view. And that's why the hurdles in radiology are not as high as they are in the middle here in pathology. The view here is that the pathologic diagnosis is the basis of everything that follows afterwards. treatment decision of the oncologist, the decision what to test for, the diagnosis, the basis of the pharmaceutical trials, studies, insurance claims, etc. And to that end, that's the ultimate ground truth. And so today, speaking of all the hype you're hearing of, but today in pathology, there's just one single approved AI. So just one. So if you think of everything you hear about machine learning AI, the road to actually clinical application is so long and hard that at the end of the day, you actually just, if you want to stay in a regulated framework, you only have one system today. And that was approved last September. So that's the difference the FDA sees between pathology and these screening technologies. And that's why it's worth investing time and effort to build systems, machine learning systems that can help pathologists to be more robust and reproducible and improve the final diagnosis. The way we do that is computational pathology. In my lab, that's more or less partitioned into three parts. So on the diagnostic side, we are building systems that help pathologists do what they already can do. For example, find cancer, grade it, classify it, but to help them to be faster, more reproducible, more robust, and so forth. The second area is the prognostic and predictive area. And here we try to build systems to do things pathologists can't do yet. For example, based on the morphology of an H&E slide, predict response to IO treatment. Or based on the morphology, try to predict biochemical recurrence in prostate. Or in cholangio, try to predict survival of the patient based on the tumor microenvironment. All of that is underpinned by a lot of work, basic computer science work, where we build information systems, where we can actually pull data from various databases. We build high-performance compute clusters with dozens of GPUs. We built then the software stack on top of it. We also built a slide viewer. It's like Google Maps for these very large slides, to foster the research processes on top of it. So where we are today. So 15 years ago, when we wrote the first computational pathology paper and coined the term computational pathology, we were just working on one slide, one tissue microarray. Over time, these data sets slowly grew, but these are mostly academic data sets, until you have 500 to 1,000 slides usually today, which is a lot in terms of computer science. 500 pathology slides, because they are so large, are equivalent to the whole ImageNet database on which most computer vision algorithms are developed. But practically, from a medical point of view, they're still very, very small if you just have a few hundred patients. And the problem here is they're also very well curated. So all difficult cases are removed, all badly processed slides are removed. And based on that, it's easier to produce high performance numbers, large AUCs, and so forth. You can imagine it's really like training a self-driving car on an empty parking lot where it will work perfectly and you will have perfect precision and accuracy. But as soon as you hit reality, it will fail drastically. And reality, especially in pathology, can be on these slides, can be very messy, diverse, surprising, and so forth. And the goal here is to build clinical grade systems that can actually deal with reality and not only just with small academic data sets. So what does it take to get there? And that list here is not just the case for pathology, but that's true for all the disciplines here at Mount Sinai, where you want to build high-performing AI systems. So first of all, it takes new machine learning. The data, for example, in pathology is so large that it vastly goes beyond what you usually do at a technical school. And there are no off-the-shelf tools you can use to, for example, classify whole slides. So it takes new algorithm development to work at that scale. Second of all, you need enough data to represent reality. The same way a pathologist cannot learn pathology by reading a textbook, but by empirically learning it from their teachers through years of sign-out. The same way an algorithm has to see enough data that represents the variability of biology you would encounter in reality. Thirdly, domain expertise. And that's not only pathologists and oncologists and medical doctors, where we have the luxury at Mount Sinai that we have a lot of interested physician scientists who are working with us, but that's especially computer scientists. So these days, when you do a PhD in machine learning, you're going to have an offer from Google, Microsoft, or Facebook on your table before you hand in your thesis. And it's tremendously hard for us as a medical institution to attract talent here. We cannot compete in salaries with these tech companies. All these students can just go 2 blocks down the street and work for Facebook or Google. And we are just not competitive at all. The only chance we have to actually attract talent is to make sure that we find the ones who are interested in the mission, who are interested in the cause of doing something meaningful with their talent, and don't spend their time and expertise stratifying teenagers at a social media company or doing ad placement at one of the other places. So attracting these is very difficult. To that end, we do now a lot at Mount Sinai in the General AI Initiative. We have a new PhD concentration for AI and emerging technologies. We have outreach events. There's going to be a new a renovated building at 3 East 101 by the end of the year, which should be a very nice place to attract talent. So we're going to hope to attract expertise to Mount Sinai that we can build the things I'm talking about, not only in pathology, but across all our disciplines. And lastly, very often overlooked is computation. So to build systems that can train from hundreds of thousands of slides and build these very deep neural networks with billions of parameters, you actually need supercomputers like Minerva we have here at Mount Sinai, but they have to be significantly built out with GPUs to cover that need. So that's what it takes. So we'll touch on all of these. So first one, scanning. That's still a slide from MSK where we started in 2015. Mount Sinai also started digitizing a few years ago. And at MSK, there are now 4.6 million digitized slides. And at Mount Sinai, we have a plan to ramp up clinical scanning to catch up and hopefully overtake like Kettering in that matter. So these larger data sets now allowed us to build systems on a set of slides at MSK with 12,000 slides and at Page on 100,000 slides that hopefully allows us to build systems that are good enough for clinical practice. And you can see here, that's really a complete phase change in that space. So that's the switching from academic, investigative, often interesting research-based approach at the bottom to really a clinical approach where we try to build systems that can impact care. To do so, I extended the cluster at MSK and built the cluster for the spin out. And what you see here are beautiful GPUs on the bottom right. I hope you are also as excited as we are, because we are all, of course, nerds at heart who love that stuff. Hardware is one thing. The second thing is software. So you actually have to build the software to compute on these hundreds of GPUs. It's multi-node and multi-GPU computation. And then you can actually approach the problem. And one of the biggest issues in practice in machine learning, and it's true in pathology, radiology, in most disciplines, is manual annotation. So the classical approach you see on the left is you have a domain expert that annotates the data. For example, by painting on an image, here you see a Gleason grade 3 lesion. And then you can train your algorithm by showing him examples of cancer and showing him examples of normal tissue. The problem, of course, is that regardless how much money you throw at that, you can never annotate 100,000 slides. It takes an hour to annotate a slide in that manner, at least. Second of all, you are actually overfitting to the person annotating the slide. And that's usually not your subspecialized pathologist who is doing that since 20 years, but a poor fellow or resident who is forced to do that. So you don't have the best expertise doing so. So how could we overcome that? And what you see here on the right is how we try to do that. And here we learn not from these manual annotations, but from the pathology reports directly. So from a report, you extract some information, for example, cancer present or not. That's just a binary variable, yes or no, for a single slide or a part. So for that slide, you do not know where the cancer is. You do not know how it looks like. You only know that there's cancer or not. You could do the same thing then with genetics and survival as well. So the problem, of course, is, and here's a prostate cancer needle biopsy, that the lesion, if you zoom in, can be tiny, so 300 pixels here. And finding that in these large slides would be impossible by using standard methods. The way we solve this is by developing a new approach based on multiple instance learning. So on a very high level, it works as follows. You have one stack of slides for which you know they're all negative, and you have one stack of slides for which you know they're positive. What the algorithm now does is it compares these two stacks of slides over and over and over again to find out what the difference is. And the difference is not normal tissue, it's not folds, bubbles, mimickers of cancer. The only difference between these two stacks of slides is the cancer morphology. And that's how it learns. More specifically, we partition these large slides in tens of thousands of small images. Here we call image patches. Then we do a forward pass through a convolutional neural network. You end up with a ranking of these patches for being cancerous or not. And then we look at, for example, the highest ranked patch. And then the hypothesis is, if it's a negative slide, then all of these patches should be negative. If it's positive, then at least one. If it's a large lesion, multiple of these should be positive. And that's now something you can compare to your pathology report, to your slide level report, calculate, as you call it, a loss function, and back propagate it through the system, update your hundreds of millions of parameters in that network, and do that over and over again. And that's how you train that convolutional neural network based on a pathology report instead of manual annotations. When you get a new slide to test you have not seen before, you again partition it in small tiles. Then you do a forward pass through your trained convolutional neural network here. You end up with potential locations of cancer, and then you aggregate across a slide. In that Nature Medicine paper, we did it with a recurrent neural network, but you can also use attention-based aggregation methods, which then ends up with the final diagnosis. So that's a system that for the first time was able to actually train AI from that large number of slides, which was impossible. We did that preprint in 2018, and it was in Nature Medicine in 2019, and it's currently in the 99th percentile of all Nature publications, because it showed that phase change in the discipline. So I've done a lot of plots in my life, and of course, usually they are not very important. You forget them, but that's one I'm quite proud about. What you see here on the x-axis is the data set size, and on the y-axis you see the error of these models. So if you train that kind of model with just a few hundred or 1,000 slides, then you have very high error rates, 30–40%. But if you start training these with 6, 7, 8, 9,000 slides, the AI really starts to learn by itself how cancer morphology looks like. And if you do that with tens of thousands, the thing really gets very, very good in doing that. We tested it on prostate cancer, BCC in skin, and breast cancer mets to the lymph nodes. You see very good AUC curves here. And if you do a little bit of mathematical gymnastics, you can actually back project the results into the image and show the pathologist where the cancer is that led to the classification of these slides. Okay. So at that point, you should be very suspicious if you listen to me, because I told you you shouldn't listen to anybody who tells you they have great AUC curves on just some academic data sets. That was a large data set, but maybe it was just very MSK specific, very nicely curated. Who knows if that is actually useful in practice? And that's the questions you should always ask when somebody comes to you with some AI algorithm. So to overcome that, we ran a study and tested it on 12,700 patients from all over the world. So these patients came from 800 different institutions out of 45 countries. That means the pre-analytics were done in vet labs, in histology labs, in China, in Europe, in South America, all over the US. And as you can see, the algorithm, the system retains performance quite well. There's a little bit of drop here in the paper where we used a model on 10,000 slides. But if you train it on 100,000 slides, you actually keep performance across the globe. And that's important because if you have slides from France, they still use saffron, for example, to see the collagen in the staining. The slides can be thicker, thinner. The histological, the pre-analytical differences globally are quite drastic. But the reason the model can actually deal with that is that, like a human, it truly looks at the morphology and can ignore all these nuances, if it's darker or brighter, or if there are folds and so forth. And on these test sets, we use every single slide. So there was no data curation done. Every slide that was good enough for a human had to be good enough for the AI. And that's what we defined as clinical grade. Everything that comes into the clinic has to be used by the AI. Then you can do some model introspection. You can actually look at these slides, see the different clusters of cancerous and benign. And you can use it also to paint slides and show where the cancer is. That's an easy one where the cancer is rather large. The interesting cases are where it's really a teeny tiny needle in the haystack, and the pathologist spends a lot of time doing so. Okay. So at that point, it was a nice academic project. It was nicely published. It was very well received, but it still would not impact care in any way. And to do that, oops, oh, I'm sorry. So to do that, we founded a spin-out at MSK called Page to have built industrial grade software and go through the regulatory process. So we start talking to the FDA in 2018 already. And it was a very, very long process. Various studies. The final study was then submitted. The whole material was more than 2,000 pages because there was at this point never ever approved AI in pathology. In February 2019, we got breakthrough designation by the FDA. That was the first breakthrough designation for an AI, not only in pathology, but in all of oncology. And you only get that if you can show that you have potential to really impact patient care. Okay, so 3 years later, we were very, very honored to get FDA approval in September last year for prostate cancer. And the director of the FDA even said that this, in their press release, that this technology ultimately can save lives, which the FDA does not say lightly. And that was also amplified by Janet Woodcock in her statement, which was very humbling. But it shows what we can do in AI. So the question is, how was that actually proven? Because what the FDA is interested in is not so much the retrospective studies I've shown you, but a study that shows how the device, it's a medical device, would impact the decision-making of a pathologist in clinical practice. So to that end, we had to design a study with data from 217 different institutions out of 22 states of the US with multiple ethnicities and also patients from 5 countries externally. Then there were 16 pathologists part of the study, GU specialists and generalists. They were reading slides remotely and in the lab, and they had between 2 and 34 years of experience. And the first thing you look at is the sensitivity. And here's a good case of a prostate needle biopsy, 1 core. And what the pathologist had to do is they had to first try to find the cancer as they usually do, and then with the help of the AI in the second step. And that's a case where all pathologists agree there is no cancer. And it's a benign case. But then the AI pointed out that there in fact is a small lesion at the border here, and it's actually a Gleason grade group 4 lesion, so something you should not miss, which informs treatment. And based on that, the pathologist changed their opinion to either classify it directly as cancerous or to ask for additional tests, so they deferred the case. And overall, the study showed that the cancer detection errors were reduced by 70%. So the sensitivity of the pathologist significantly increased, and that was true across all training levels, non-uropathologists, uropathologists. It was true for reading remotely and on site. So that's great. But if you look back into the past in radiology, you can actually buy high sensitivity by just giving up specificity. And you have these old AI systems where you have false alarms all the time, so the pathologist just turned them off. And that can be very challenging in this area. So here's another needle biopsy. What you see here on the left is beautifully seminal vesicle, but on the right, on the other part of the slide, you have morphology that looks cancerous. Most pathologists actually classified it as cancer, while the AI said it's actually benign. And it was benign, and then the pathologist either asked for additional tests or followed the AI. And some of them did not, of course, that leads to the error rates. And what the study showed is that even the specificity went up, and the false positive rate was reduced by 24%. So that's very nice to see. So you have now an algorithm that clearly helps pathologists to find cancer when there is one, and does not produce additional false positives. Good. So back to Mount Sinai. So at Mount Sinai, the plan now is to actually learn from that experience. So I showed you the whole path in pathology from 15 years ago, our first computational pathology paper. For 10 years, nobody cared the least about some computer scientist doing something on some old slides. Then the hype in the last years showed you how you actually then can go beyond that, build compute clusters and systems to build clinical grade AI, and then finally take these systems, go for years through the regulatory process, and end up with a system that's used for patient today in Brazil, in the US, and in Europe, and improves outcome for patients. So what we want to do now at Mount Sinai is take these learnings and replicate them for the different areas. And that's part of the AI initiative and my role to help you in your work to take what we learned and apply it for your area. Because at the end of the day, and that's now we are going up to the high level vision again, what we really want to build is an AI fabric across the institution. I talked about pathology today, which gives you a small sliver of information about the patient's disease. But of course, you have radiology and cardiology with imaging techniques, and urgent care and psychiatry and surgery, and all the different areas at the institution where potentially AI can help the physicians and the patients. And the hope is that we can build systems in these areas and then connect them to really build a fabric across these AI services. Okay, again, everything I talked about only possible because of the fabulous people at Mount Sinai and everybody who worked on these projects. And it's an honor to work with all of you here, and I'm very excited about building out AI at Mount Sinai. Good, thank you very much, and I'm looking forward to questions.
Great. Thank you, Dr. Fuchs. We do questions in the chat so that we can get everyone and I can.
I'm very sorry, I have some audio issues. 1 second.
That's all right, take your time.
Oh, yes, I can hear you now. I'm sorry.
That's okay. I would say the people will put questions in the chat. There's a couple in there already. I can help with them. The first question is, what do you use as the gold standard in these studies?
So the FDA recognized the final diagnosis at Sloan Kettering as ground truth. The rationale being, the final diagnosis is based usually not on the opinion of a single pathologist, but you have a consensus sign out. The pathologist can actually order additional tests. So you can have additional levels. You can have molecular tests. You can have all kinds of IHC stains, and the pathologist is able to look at the whole report of the patient. So to that end, it's actually quite unfair towards the AI algorithm that only can look at the H&E slide. But because of all of that, the FDA recognized the final diagnosis as at memorial, as ground truth. And I'm sure that would be also the case with the diagnosis as Mount Sinai, because there is no other place to appeal to if you are at places like ours.
There is a question that says, do you have patient-level clinical outcomes from the change in diagnoses? Could we be increasing the numbers of people treated for prostate cancer who didn't need treatment and would never have had symptoms from the disease?
Very, very good point. So first of all, that's why the specificity was so important in that study, because you do not want to increase unnecessary treatment. But I only talked about cancer detection in the talk. What the system now also can do is actually grade the cancer automatically, Gleason grading percentage and so forth, which is great, but that still resembles only the grading schemes we have today. What's the next step in computational pathology is to train these systems against outcome. What you really would like to have is something like a Gleason grade plus that helps you to better predict response and, for example, find the patients where you would not want to treat. In prostate cancer, luckily for the patients, difficult for the scientists, these follow-ups have to be 20 to 30 years. So we started digitizing some cohorts, also in some European places, to actually get to these larger outcomes to test that. And we should also do that at Mount Sinai. That training these systems directly against outcome is the best way to go. We had a publication in cholangio where, unfortunately, of course, the survival is much shorter, and you have survival data on patients. And there the question was, because there's no grading scheme in cholangio, can you actually find subgroups of patients with different survival outcome where the morphology is different? And the AI hinted at morphological differences and could nicely separate patients. So we are now investigating if these morphological differences actually lead to have some functional differences.
Another point and question. The data for diagnoses are terrific. For prognosis and prediction assessment, there is a role for added information from protein expression and genomic data. Can AI algorithms integrate these data in a robust fashion?
Yes. So that's a two-edged sword. So first of all, from a machine learning point of view, absolutely. What you always try to do is integrate as much information as possible. So multimodal approaches where you do radiology, pathology, genomics, for example, of course, perform better. What we did, for example, are models where we also integrated MSK Impact, the sequencing panel at Sloan Kettering, to these models to improve prediction. But if you think that through, for example, in lung, right, one of the big problems is that if you have a sequencing panel, first of all, is very expensive and takes weeks to actually get response to. So a thoracic oncologist usually wants to start treatment before you actually get these results back. So and there we're trying to build systems that can directly predict response, for example, to pembro or other IO drugs from H&E without waiting for a sequencing panel to do so, where you then use TMB as a proxy. So there's a high utility to actually build predictors just from a cheap $5 H&E slide. And what's also beautiful about that is it's really a very good example how AI can help you to democratize access to healthcare, because not everybody can afford to go to Mount Sinai or Sloan Kettering. But if you can now run the AI and the prediction is fast and cheap in the cloud, you can do that at every small community practice in pathology throughout the US and even globally in the developing world.
That relates to the next comment and question, and that is, given the country-specific control that the pandemic has led to, for example, with vaccines held by individual countries, are there any issues with transfer of information between Germany and the US?
So there are various aspects to the question, technical, legal ones. So technical ones, no, right? That study we showed that it works globally. In the meantime, we actually did also studies with Yale and Cornell and Oncoclínicas in Brazil, and it's reproducible across the globe. Legally, of course, that's completely different. You have to adhere, of course, to HIPAA here, GDPR in Europe. And that's, of course, a lot of work and needs an army of people to make sure that everything is anonymized and properly done. And the last aspect is, of course, the regulatory aspect. In Europe, you have to deal with CE mark and soon with IVDR, which are different frameworks than the FDA framework, of course.
Gotcha. There's a question, what are the greatest challenges with incorporating the fabric to all the other types of diagnostic data?
So the absolute largest challenge is talent. Right? We do not have enough people at Mount Sinai. The number of people who have a PhD in machine learning at Mount Sinai can be counted on one single hand out of our 50,000 employees. That's number one. That's a bigger problem than opening up data silos, solving political problems, helping the amazing scientists in these different areas. The problem is really having talent on the machine learning side. And again, it's not my role to do the same thing we did in pathology for the different areas, but to help somebody who wants to do that in that area. So all of you on the call, if you think that your specific area of expertise, and that might be based on, I don't know, ECG data or variables or all kinds of clinical data, could benefit from these systems, then our role is to help you do it yourself with our help.
Gotcha. After treatment, do you have biopsies to compare with the initial biopsy, and can AI find things that indicate the need for more treatment or not?
So we had a poster at ASCO, I think last year or the year before, where we looked at resections, right, after treatment. So prostatectomies, complete resections of the prostate. There you ran the algorithm on whole mount, so you have a complete cut through that. And then, first of all, the question is, does the system still work if you have actually atrophy because of hormonal treatment, which it does? And then the question is, based on that, can you predict likely metastasis of the cancer after treatment? That's still in the works, and the problem there's also outcome data. That's very, very hard to produce.
Gotcha. And then Dr. Powell has a follow-up question related to the lung. Can AI distinguish an EGFR mutant lung adenocarcinoma from an EGFR wild type lung adenocarcinoma based on morphology alone?
EGFR?
Mm-hmm.
Yeah, yes. Actually, we are just finishing a paper on that. Very good question. Not in the 90s. That's very important. So all these biomarkers, there you're in a different discipline. But that's the baseline here is how current biomarkers do. So EGFR is a different case, because what you want to do there is to actually build a reflex test, right? You want to test immediately on H&E, and then only send the questionable cases, for example, to slow and long sequencing testing. In the IO response case, right, there the baseline is very low. So PD-L1 staining, IHC PD-L1 staining, manually assessed at slowing catering, predicts response of the tumor in terms of RECIST just with 0.7 AUC. And that's where we are. And tumor mutation burden is even worse, right? You're 0.65 on the largest cohort yet published for first-line IO treatment in lung. So there we could show that you can actually build a computational model that's equally bad or good as the FDA-approved biomarkers, but it's at least cheaper, faster, objective, and reproducible, and has the potential to go beyond of just looking for PD-L1. So that's very important to understand. Same thing with genomic prediction. If you look at EGFR, you're not in the 90s, but you are in an area where it can be very useful to screen.
there's a question around how successful is this platform in establishing conclusive diagnoses of melanoma, especially amelanotic melanoma?
So very important, first of all, so the system does not render the final diagnosis, right? It's a support tool for the pathologist. The FDA-approved system solves the needle in the haystack problem. The problem of, first of all, finding the cancer. It does not render the final diagnosis and will not for a long time. So that's up to the clinician and physician who takes in all that information to come up with the final diagnosis.
Gotcha.
To the skin cancer question, so we had several papers on BCC that works rather straightforward. We are looking at melanoma, and there's work from other groups out there in melanoma that is, I do think, very promising. Problem with derm is that dermatopathologists are so fast, and they just look at one slide instead of a breast mastectomy where you could have 200. That it's actually, they are already super efficient. It's a big difference.
Interesting. How can you avoid incorporating structural racism into the AI outputs when much information about social determinants is absent from the calculations, but likely affects the outcomes?
Yeah. So the way to do that is first of all, before you even train this system, from the beginning, when you design this project, you have to have these aspects as part of your design of the system, the same way how you design another study. Right? So the AI is not different in that way. Right? If somebody does not design a study properly, and that could be, I don't know, a simple blood test, right? Then it will not work, and the same thing is with AI. So practically, and we had to do that in meticulous detail for the FDA, you have to make sure that your test sets are designed properly to show that it works across the areas you're interested in. We are extending that work actually with work with the VA, where the VA is, of course, very interested in prostate cancer and has also a large population of African American soldiers who have to benefit from these systems equally. To this day, we do not have seen differences based on ethnicity, but that's something you also have to constantly monitor. And maybe to add for everybody else, so one thing we started here at Mount Sinai is AI ethics initiative, which is now led by Bruce Darrow, which also will come up with guidelines for two purposes. First of all, for building our own AI. So what you want to do is to, of course, support if young faculty that comes to Mount Sinai and wants to build AI, to help them to do that in a proper way, right? So that it is not only safe and effective, but also equitable. And in addition, when somebody externally comes to you and say, test or use our AI, a company, Mount Sinai has to have a framework to make sure to test external AI if it's not FDA cleared.
Gotcha. Given that healthcare is one of the most costly services provided in our society, why isn't Google, Facebook, et cetera, interested in collaborating with your programs?
They are. Google has a pathology group, computational pathology group. For several years, Microsoft has also won. But there's a reason why these big tech companies constantly fail in healthcare. And Google just shut down their Google Health Initiative a second time. First time they had one 10 years ago. The reason they are failing is they have all the talent, obviously. They have all the compute and all the money. But what does not work is to develop AI outside of a healthcare system and then throw it over the fence and into the system and see if it works. That always fails. To really develop systems that are meaningful in clinical practice, you have to be in the trenches. So as you know, medicine and pathology, these are oiled machineries with hundreds of steps. And if you can build all kinds of AI, but if it slows you down just a few seconds here or there, it's useless in practice. So you have to clearly understand what's going on. I truly believe, and I believed it years ago, that a change in that field can only come from within systems like ours, where computer scientists and physicians can work in lockstep in the trenches. And with the pathology example I showed you today, we proved it out, right? Neither Google nor Microsoft works at the scale we do. They don't have regulatory approval. They cannot do what we can do here at Mount Sinai.
One last question. How is your FDA-approved system being accepted? Do pathologists believe that it can improve their performance?
Yes. So looking for the needle in the haystack is no fun, right? It's an easy proposition, right? That's usually not the issue. There are more basic issues that a lot of hospitals are not digital yet, right? And you have to digitize them. Pathology is far behind radiology in that respect, right? Everybody's excited about AI to support them in their endeavor. It's also, if you look at pathology will change fundamentally in the next 5 to 10 years. So there's not one hospital who's not thinking about going digital. So if you look at pathology in 5 years or 10 years at some places, the latest, you will have no microscopes like in many places in Europe. You will have your cockpit where you got the morphology information that's, for example, worked up a system like ours, the molecular pathology information, which of course is also done mostly in pathology. There's some liquid biopsies, and you get all these data streams to come up with a final diagnosis. And that's also necessary, right? The number of cancer cases goes up, the complexity goes up, the number of pathologists goes down in the US and globally. So just to keep the standard of care, you need AI. But that also makes pathology cool again, right? I had the pleasure to be on the task force for the future of pathology by the AACR. And the biggest worry of all the chairs is that not enough people go into pathology. And these modern technologies put the pathologist much more at the center of the treatment decisions of a cancer patient than the old way, right? So the gap between the oncologist, radiologist, and pathologist will certainly shrink because you have to integrate that information. So pathology will be a great place to be, but it will be fundamentally different than today.
That's great. Well, thank you, Dr. Fuchs. Well, I thank you very much for coming and presenting today. I think you know that we in the department are very interested in partnering with you and your AI initiatives in many of our divisions. And so really appreciate you coming and giving this very extensive discussion about your field. So thank you very much.
Thank you for the invitation.
Absolutely. And have a nice day, everybody. Enjoy. Stay warm.